Hi, folks. We're just letting everybody in. And so we're going to give it a couple of minutes because quite a few folks are going to be joining. Thank you so much for joining us today.
Hello.
Hi, everyone. We're just giving everyone a couple of minutes to jump on. And I'm getting one panelist who's having a little bit of trouble joining. So 1 second. Hi, everyone. We're just going to wait one more minute for folks to hop on. Thank you so much for joining us today. All right, folks, it looks like everything has slowed down. So I am going to kick it to Commissioner Hedberg to head us off on this webinar. Thank you so much, everyone, for joining it.
Great. Well, thank you so much, Erica, and welcome everyone to the Food is Medicine and Payment Pathways presentation. My name is Heidi Hedberg. I am the commissioner for the Department of Health, and I am really excited that you guys have all joined us today. And I want to thank Erica and her team with the Center for Health Law and Policy Innovation at the Harvard Law School. They have been providing technical assistance to the Department of Health as we have really been exploring food is medicine, what it is, and the policy and payment opportunities that Alaska can possibly take advantage of. And so the time that we have here is an hour and a half. The first hour is really going to be diving into this topic. What is food as medicine? What are the policies? What are the payment mechanisms for this under CMS? Looking at other states and how other states have implemented this. And then the last 30 minutes is going to be an opportunity for questions and answers. So as you are listening to this presentation, please make sure to jot down your questions, and then we want to make sure that we have a robust conversation towards the end of our session together. All right, back to you, Erica.
Thank you so much, Commissioner Hedberg, and I will give it to my colleague, Heather.
Thank you, Erica, and thank you, Heidi. I want to thank the fantastic leadership from the Alaska Department of Health for bringing us together to talk about the growing momentum and support for expanding access to nutrition support to better serve and assist populations with diet-related illness. It is such an honor to be here with all of you today to talk about opportunities for increasing access to nutrition interventions and the payment pathways to cover the cost of those interventions in Alaska. My name is Heather Latino, and I'm here with my colleague, Erica Hansen, and we are both clinical instructors and attorneys at the Center for Health Law and Policy Innovation at Harvard Law School. The Center for Health Law and Policy Innovation works for regulatory, legal, and policy reforms in health and food systems with a focus on the health, public health, and food needs of systematically marginalized individuals. Additionally, as a teaching clinical program at the Harvard Law School, our staff mentor students to become skilled, innovative, and thoughtful food and health system practitioners. This semester, we have been collaborating with a team of 5 fantastic students who have worked really hard to prepare this presentation for you, including one student who unfortunately was not able to join us today. We are going to hear from them about some of the exciting opportunities to expand access to food as medicine for Alaskans and the potential impacts on your communities. And with that, I would like to turn it over to our students to introduce themselves. Morgan, would you be willing to get us started?
Yeah, thanks, Heather. Hi, everyone. Very excited to be here today. My name is Morgan Vidal, and I am a third-year student, Master's in Public Policy candidate at the Harvard Kennedy School and an MBA candidate at the Wharton School of Business. I'll pass it on to Natalie.
Hey everyone, I'm Natalie Ball. I'm a family nurse practitioner and a student, a Master's of Public Administration student at the Harvard Kennedy School. I'm super excited to be here and thank you all for taking the time. I'll now pass it off to Meghana.
Hi everyone, thank you so much for being here. My name is Meghana Iragavarapu and I'm a first year at the Harvard Chan School of Public Health. And I'm so happy to pass it to my colleague Zoe.
Hi everyone, my name is Zoe Van Blonderen. I am a third year law student at Harvard and I'm going to be starting us off today. So first of all, thank you all so much for meeting with us today. We're facing an incredibly exciting time in food as medicine policy in the country, and Alaska is well positioned to benefit from this momentum and launch a highly impactful program. So we are really excited to have this opportunity to share important baseline knowledge as you develop your plan for food as medicine. The purpose of this presentation today is to develop a shared understanding of the levers, actors, policies, and existing programs in Alaska and federally that will impact any statewide food as medicine plan. In particular, we will share information on topics at the intersection of healthcare and food systems that are relevant. We'd like to acknowledge that there are many experts in this room with deep skill sets and knowledge, and we're going to talk about programs and organizations that many of you lead and work for, so you will know far more than we do. However, everyone comes from different backgrounds, so we are level setting for the person with the least knowledge in each area to ensure that everyone leaves this meeting with the same baseline understanding. This presentation should last 60 minutes, so we'll take questions at the end. If you have questions in the meantime, please feel free to add them into the chat and we'll try to answer as many as we can. One final disclaimer before we begin is around language. The federal government uses terms and statutes and the names of programs that are not preferred because they refer to colonization, such as the Federal Distribution Program on Indian Reservations, or because they're gendered, such as Women, Infants, and Children Nutrition Security Programs. But we are planning to use the program names in full to avoid confusion. With that, I'll jump into our agenda today. We will begin by providing an overview of food as medicine and the foundational food and nutrition policies that support your work. We're then going to do a deeper dive into specific programs and organizations operating in the food as medicine space. Some of these may resonate with you as models to potentially include in your state plan. We'll then show evidence that demonstrates the multifaceted benefits of food as medicine in general, and specifically in Alaska, exhibiting why the program can have such a strong impact in your state. Particularly given Alaska's demographic composition, we'll review the positive health outcomes and potential healthcare savings that food as medicine can generate. Food as medicine can also deliver substantial benefits to strengthen statewide food systems and food economies. We'll review the strong economic rationale in Alaska for food as medicine. Finally, we'll discuss how you can fund food as medicine, both through the food system as well as through the healthcare system, namely Medicaid waivers. We'll wrap up with a variety of examples of implementation and some food as medicine pilots, and then turn to answering your questions. To begin, we'd like to make sure that everyone is on the same page when it comes to understanding what food as medicine interventions are. Food as medicine interventions are tailored to respond to the connection between food and health by helping to prevent and treat diet-related disease, and they have 2 components. First, the provision of food that supports health such as medically tailored meals or groceries, or food assistance, such as vouchers for produce. The second component is that interventions must have a nexus to the healthcare system. We're here to put these interventions in context and to discuss the programs operating in the food system more broadly that may support food as medicine interventions. We also want to draw at some of the operational aspects of these programs, such as the populations they reach, how they tie into procurement and the food system more generally, and finally, how these programs can be scaled to get food into the hands of people who need it while working toward the end goal of integrating food as medicine interventions into Medicaid and Medicare. Here is the diagram for food as medicine interventions for this discussion. This pyramid shows the role food can play in healthcare. The bottom of the pyramid is the broadest category of how the food system can support food as medicine, which is about generally ensuring population-wide food access and establishing healthy food as a norm. As you move up the pyramid, each level is about targeting key population groups with more specific interventions. The very top of the pyramid is medically tailored meals, which is the intervention aimed at delivering fully prepared meals to those living with severe illness after a referral from a medical professional or healthcare plan. Each person might move up or down the pyramid, depending on their health status and needs. You will likely be focusing on interventions at the top of the pyramid. Those are the interventions with the strongest nexuses to the healthcare system and that Medicaid, Medicare, and other health insurances have been and are more likely to cover. It's important to remember that interventions at the top of the pyramid, such as medically tailored meals, stand on the foundation of broader food access programs. If we build up the bottom of the pyramid, then we build population-level nutrition security and health, lessening the need for more intensive interventions. The rest of the presentation will walk through each category of the pyramid. While we give an overview of many interventions related to food as medicine, the purpose of this landscape presentation is to give you insight into the broader scope of interventions and a menu of options that you may potentially want to consider. You certainly do not need to tackle all of these issues at once. I'm going to turn it over to Morgan now, who's going to provide us with an overview of population-level programs and policies relevant to Alaska.
We're going to now dive into the pyramid and the types of interventions that may be applicable for your food as medicine plan. We do understand that some of you are currently meeting with stakeholders throughout Alaska to build a strong understanding of the landscape in the state. This asset mapping is a very important step to understand what programs already exist and how they might be leveraged to support the expansion of food as medicine. As we move throughout the pyramid, we will be highlighting a number of programs, some that are Alaska-based that you may already know well, as well as other examples throughout the country, to help provide additional context for how this work can be operationalized. With that, I'll start by jumping into the bottom rung of the pyramid, which are the population-level healthy food policies and programs. These are prevention-oriented, focused on food and nutrition from an education and access standpoint. I'd like to specifically highlight 3 categories of population interventions. These are community gardens, local food access, and teaching kitchens. Community gardens are public plots of land where community members can grow, consume, and sell their own foods. These are often funded by donations or grants, but some are even for-profit, generating sustainable funding streams. They are often also integrated with local school systems. Local food access programs and policies expand access to nutritious and local food. These programs may increase the number or accessibility of healthy food stores and farmers markets, or they may improve healthy offerings in existing locations, such as food banks. Policies may also seek to change zoning laws to reduce the prevalence of unhealthy food stores, or require that procurement considers a product's origin in order to emphasize local foods. Finally, teaching kitchens offer hands-on and educational resources focused on things like cooking, food harvesting or preparation, and nutrition. This may also include using nutritious foods in combination with healthy lifestyle information, such as exercise and developing healthy relationships with food. While these population-level efforts are not food as medicine interventions that can be funded by Medicaid, they do address the root social determinants of health, helping to prevent or lessen the diet-related chronic diseases and the need for more intensive, costlier interventions higher up the pyramid. The frameworks employed by the many Alaskan organizations already doing amazing work here, some of which are highlighted on this slide that you can review after the presentation, should be leveraged. Any opportunity to integrate or repurpose existing infrastructure into food as medicine can help to strengthen local and sustainable food economies. We will now turn to the nutrition security programs or food access programs, which again still fall in this prevention category. These programs are typically targeted at addressing hunger more generally, regardless of health status. The primary examples we will discuss are the Supplemental Nutrition Assistance Program, also known as SNAP, the Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC, and the Federal Distribution Program on Indian Reservations, or FDIPR. I'd now like to take this opportunity to distinguish food security from nutrition security. Food security focuses on reliable household access to enough food in order to lead an active, healthy life. The emphasis here is on quantity over quality. Comparatively, nutrition security looks at the nutritional value, affordability, accessibility, and safety of foods that promote well-being. Programs can promote both food and nutrition security or choose to focus on just one or the other. However, from a policy perspective, it's important to consider the goal of each program with respect to food access. While these nutrition security programs are not food as medicine, the baseline food and nutrition security are very important foundations to prevent the more intensive interventions further up the pyramid, as Zoe mentioned. These programs are federally funded, but they're administered by Alaska state agencies, Indian tribal organizations, and local initiatives. Adjustments have already been made at the federal level to tailor their implementation, given Alaska's unique characteristics. Now we'll review how these nutrition programs are operationalized in Alaska throughout the next few slides.
Thanks, Morgan. First, we'll go over the Supplemental Nutrition Program, SNAP, that provides funds to participants to purchase food. SNAP is a national USDA program administered by state agencies. To be eligible for the program, the participant's household must make under a specified gross income, depending on the number of household members. This is especially important for a food as medicine program because the population who qualifies for and benefits from SNAP is likely to overlap significantly with the target audience for a food as medicine program. This overlap is critical considering the link between chronic nutrition-related diseases and income. Regarding logistics, SNAP recipients get their benefits on an electronic benefit transfer or EBT card, which is a debit card that they can use at an authorized grocery store and farmers market. In Alaska, SNAP authorized markets and farm stands offer a dollar-for-dollar match up to $40 a month for customers using SNAP benefits to purchase qualifying food produce. This program, known as AFMA Market Match, is administered by the Alaska Farmers Market Association and funded by the state legislative grant program. SNAP benefits may also be used at some online stores for delivery. However, the benefits cannot be used to pay delivery fees. There are two specific Alaska SNAP modifications I would like to mention that are designed to address the challenges posed by the state's remote location and higher cost of living for its residents. First, a higher monthly allotment. Individual and households receive a higher monthly SNAP allotment compared to residents of other states. This adjustment takes into account the increased cost of living in Alaska, including higher food prices. The second, the special subsistence and hunting fishing rules. Recognizing that many Alaskan residents rely on subsistence activities, such as hunting and fishing for their food supply, especially in remote areas with limited access to retail stores, SNAP benefits can also be used in some areas to purchase hunting and fishing equipment. In the same way, the SNAP program has been modified to adapt Alaska's unique environment. Food as medicine programs should similarly be tailored to the needs of Alaskans. Nutrition education initiatives can be funded through SNAP-Ed. For example, Alaska's SNAP-Ed Every Bite Counts program aims to educate SNAP beneficiaries on healthy eating practices, nutrition, and cost-effective food selections. Overall, SNAP and related programs, which tag onto SNAP, are focused on access and getting food into the hands of those who need it, rather than more tailored nutrition security, which we'll talk about a little later. However, SNAP and other services at this level of the pyramid serve an important role as a step-down service for food as medicine. By maximizing access to SNAP and other food access programs, we may better break the cycle of food insecurity and chronic illness. So maximizing access to SNAP may help reduce the need for food as medicine in the long term. There are also ways to use federal SNAP funding to reach food as medicine populations. For example, some food as medicine programs use SNAP-Ed funding to provide nutrition education as part of their services. Regarding Medicaid waivers, which can be used to cover nutrition screening and food interventions, based on a recent framework from the Centers for Medicare and Medicaid Services, CMS, we expect that state Medicaid agencies will be required to partner with state and social service agencies to ensure that beneficiaries experiencing food insecurity are connected to programs like SNAP, as well as other security programs such as WIC, a program that Morgan will now dive into for us.
So WIC is targeted to improve the nutrition of mothers and children who meet income eligibility guidelines, and they've already been identified as at nutritional risk by a healthcare provider. WIC participants receive funds on their eWIC debit card to use primarily at approved retailers to purchase pre-approved foods. Participants can also receive peer counseling, nutrition education, breastfeeding support, and referrals to other programs like Medicaid and SNAP. At its core, WIC is really a food as medicine intervention because unlike the other federal food assistance programs, it requires a health evaluation from a qualified healthcare provider and then accordingly provides a tailored food package. Research has shown that WIC is an extremely cost-effective investment to improve the nutrition and health of low-income families. However, there is still some room to improve Alaska WIC. As of 2021 data, Alaska ranked 25th on WIC coverage, meaning only about 51% of eligible people participated in WIC. Unlike SNAP, which provides a set dollar amount that can be spent on any SNAP foods, WIC has very strict limits on the types and sizes of foods that can be purchased. Traditional foods are also largely excluded. The USDA has proposed some changes to WIC as of last year that would help improve WIC coverage and improve nutrition security, including permanently increasing the cash value benefit for fruits and vegetables and giving local agencies and Indian tribal organizations more flexibility in the types of foods that they offer. Finally, I'd like to reiterate a key takeaway that Natalie discussed, which is that under the new CMS framework and the 1115 waiver process, state Medicaid programs may be asked to capture the percentage of their beneficiaries who are enrolled in WIC and SNAP and develop a strategy for improving WIC and SNAP coverage among Medicaid beneficiaries. It is our understanding that Alaska WIC does not currently have a written agreement with Medicaid or SNAP, although the data is periodically shared between the organizations in order to identify enrollment gaps. And finally, that WIC representatives do occasionally meet with counterparts at both Medicaid and SNAP. The Division of Public Assistance under the Department of Health currently administers both WIC and SNAP, and it also determines Medicaid eligibility, which is very beneficial for enrollment coordination and coverage improvement across these programs. Of note, Medicaid is separately administered by the Healthcare Services Office. Additionally, there is already a joint Medicaid and SNAP application, although the WIC application does remain separate. Streamlining the application process across all three can be another impactful channel. Coordination and collaboration between WIC, SNAP, and Medicaid is crucial for improving health outcomes across the state, and particularly for vulnerable populations like food as medicine recipients and mothers and children. The final nutrition security program that we will discuss before moving into the food as medicine interventions is FDPR. FDPR is an alternative to SNAP that also targets a very low income population. Recipients may switch between the two programs, although they cannot receive both SNAP and FDPR benefits at the same time. To be eligible, participants in Alaska must meet federal income guidelines as well as residency and tribal membership requirements. The USDA procures and distributes food in addition to funds that cover administrative program costs to local agencies, either Indian tribal organizations or state agencies. These local agencies are then responsible for storing the food and distributing it to participants, determining eligibility among applicants, and finally providing nutrition education. Notably, there has been a drop in FDPR participation across the country, but Alaska's participation has been dropping even more quickly. There are several hypotheses as to what is driving this nationwide trend, but they largely center around a reduced budget and a lack of food sovereignty. Reasons may include USDA administering staff without appropriate experience and knowledge, the provision of unfamiliar or unwanted foods, and a lack of accompanying information about how to cook and prepare the provided foods. One pathway to increase participation is FDPR's self-demonstration project, which grants tribes flexibility to procure desired traditional foods from their preferred vendors. The Alaska Native Tribal Health Consortium was selected to participate in the project. Expanding the project's reach and incorporating its learnings can help increase FDPR participation and support the development and implementation of food as medicine programs that target similar populations. Another USDA program that also refocuses procurement on local and traditional food systems is a new pilot aimed at offering more localized ground bison meat for tribal communities through FDPR. This pilot will change how USDA purchases bison to better support buying the meat from small and mid-sized bison herd managers and delivering it directly to local tribal communities. This pilot does focus on the Dakotas, both South and North Dakota, but it's still a useful framework that can be applied to working with Alaska Indian tribal organizations and in supporting the development of food as medicine programs that wish to procure local, culturally appropriate foods from smaller and tribal producers. We've now wrapped up the prevention section of the pyramid, and Zoe will begin reviewing the types of food as medicine interventions at the top half.
Thanks, Morgan. Now we're going to turn to food as medicine interventions, starting with produce prescription programs. With the exception of the WIC program, which Morgan discussed a moment ago, the federal nutrition programs we've been discussing at the bottom of the pyramid are not tailored to meet the specific health needs of participants. We're now making a transition into interventions with a direct nexus to the healthcare system. Produce prescription programs, medically tailored groceries, and medically tailored meals are interventions prescribed by a medical provider to address a diet-related health condition, and thus can be paid for with Medicaid funds. Produce prescriptions provide participants with funds via vouchers or tickets, which recipients can use to purchase fruits and vegetables. Produce prescriptions often have participation requirements where the recipient must meet certain health criteria and be referred by a healthcare provider or insurer. Thinking back to the definition of food as medicine we discussed, produce prescriptions respond to the critical link between nutrition and health by tapping into the healthcare system to increase access to and consumption of fruits and vegetables. As we move further up the pyramid of food as medicine interventions, produce prescriptions have a stronger tie to addressing diet-related disease versus food or nutrition security more generally. Produce prescriptions are targeted toward patients with at least one diet-sensitive health risk or chronic condition, such as diabetes, prediabetes, hypertension, obesity, or heart disease, who also have low incomes and are food insecure. In Alaska, the Yukon-Kuskokwim Health Corporation implemented a produce prescription program in 2019. The program provides monthly $45 food vouchers to patients covered by Medicaid who are at risk for developing diabetes or diagnosed with diabetes that they can use to support increased purchases of fruits and vegetables. This is happening in a region that sees some of the highest poverty levels in the nation and extremely high grocery costs. Natalie is now going to move us further up the pyramid in discussing medically tailored groceries.
Medically tailored groceries are food packages that include a variety of unprepared or lightly processed foods, such as produce, whole grains, and legumes, and lean proteins that the recipient must prepare and cook. These grocery food packages are intended to provide the participant with all or most of the nutrition they need. While the grocery items are approved by a registered dietitian nutritionist as part of a treatment plan for an individual with a specific medical diagnosis, such as diabetes, hypertension, high cholesterol, HIV/AIDS, congestive heart failure, COPD, the packages are not usually designed specific to an individual's health needs, but rather to address the specific diet-related health conditions. While this intervention is often prescribed for individuals who have a food need and diet-related illness who can still shop and prepare their own food, some programs will deliver groceries to patients who are not able to shop. Programs sometimes make nutrition education and recipes available to recipients as well. I now want to spotlight an initiative in Watauga, North Carolina, the Hunger and Health Coalition, or HHC. The Food as Medicine program at HHC, accessible through hospitals and community clinics, targets patients with diet-related chronic diseases and food insecurity. Medical providers prescribe medically tailored boxes, which can be picked up at HHC locations or delivered through their mobile service. Upon enrollment, participants provide dietary preferences, medical needs, and allergy information. These boxes, suitable for the entire family, which is a great touch, are customized for conditions like those mentioned above, and also cater to cultural and dietary restrictions like vegan, kosher, and halal diets. HHC also provides individual nutrition counseling sessions with a full-time registered dietitian alongside healthy recipes and cooking classes, all aimed at promoting well-informed, healthy choices for patient well-being. The major takeaway with medically tailored groceries is that they differ most from food access programs because they specifically address the diet-related illness and treatment. They also differ from produce prescription programs, as the food items are selected in partnership with the registered dietitian nutritionist or other qualified health professionals who provide the patient with food targeted addressing a specific health condition. Moving further to the top of the pyramid is the most intensive nutrition intervention, medically tailored meals. Medically tailored meals are fully prepared, ready-to-eat meals, which can be reheated in an oven or a microwave, and snacks specifically tailored, again, by a registered dietitian nutritionist to meet the needs of an individual with a particular medical diagnosis, symptoms, allergies, or medication side effects. Medically tailored meals are meant for the patients that have the most complex and/or terminal illnesses or co-occurring conditions that make it difficult to shop or cook their own meals. Medically tailored meals are typically provided on a short-term basis and require periodic recertification by a medical provider or any ongoing need for the medically tailored meals. A case example I'd like to highlight is Alaska's dinner factory's Alaska Fresh. Alaska Fresh is a delivery service that brings prepared meals, such as ready-to-eat lunches and microwavable dinners, directly to its customers, accommodating both insurance and Medicaid reimbursements. The nutritionally balanced meals are approved by a registered dietitian. Alaska Fresh is an illustrative example of how food as medicine programs can be operationally supported through Medicaid funding. This program not only addresses the nutritional needs of seniors and populations with diet-related disease by providing them with medically appropriate meals, but also funnels Medicaid and other funding back into the local economy. The biggest takeaway with the medically tailored meals are that they are integrated into healthcare, funded through insurance or Medicaid, as highlighted in the Alaska Dinner Factory example, to provide that nutrition support as part of treatment for chronic or terminal illness. Medically tailored meals benefit the sickest members of our communities or the top 5% of patients that generate 50% of healthcare costs. As I mentioned earlier, medically tailored meals have proven to be effective in improving health while decreasing the total cost of healthcare, which Megan will now go into highlighting.
Thank you, Natalie. And we are now going to transition, as Natalie said, into the evidence-based case for food as medicine. So as we wrap up developing a collective understanding of what exactly food as medicine is, we must understand the landscape in Alaska, particularly the healthcare landscape, to help prime ourselves to best understand how these initiatives and programs we'll be discussing next can be tailored to suit the specific and unique needs of Alaska. We'll begin with food insecurity. The USDA defines food insecurity as a lack of consistent access to enough food for every person in a household to live an active and healthy life, a definition that we covered in the beginning of the presentation. As we know, this can be a temporary situation for a family, or it can last a long time. And we mentioned food insecurity because it is one way we measure how many people can't afford food. In Alaska, roughly 10.7% of residents struggle with food insecurity, which is actually below the national prevalence of food insecurity of 12.8%. We also want to note that this number of 10.7% may not represent the 59% of Alaskans who live in rural areas where the prevalence of food insecurity is likely heightened. Further, Alaska has approximately a 3 to 5 day food supply available in most stores. This is important to point out when we consider thinking about sources of food and incorporating the local food system and stakeholders in Food is Medicine programming. We raise these facts to simply draw attention to the ways that Food is Medicine interventions can intervene. Next, we'll move to the prevalence of diet-related chronic conditions in Alaska. We've included the prevalence of a few diet-related diseases: overweight and obese, high blood pressure, and high cholesterol as of 2021 in Alaska. The common causes of death in 2021 were cancer, heart disease, and COVID-19. All three diseases either diet-driven or exacerbated by poor diet. As we move through the rest of this presentation, we urge listeners to keep this brief healthcare landscape in the back of your minds to help consider how Food is Medicine initiatives and programs can be structured to suit Alaska. We want to next highlight some of the reasons why there has been such an immense momentum to implement these policies across the country. There are real positive health and health outcomes to these interventions. First, we'll begin with the health benefits. Studies have shown that Food is Medicine interventions, such as the medically tailored meals and produce prescriptions, are associated with significant improvements in fruit and vegetable intake, food security, and health outcomes. We've also seen documented clinical improvements in glycated hemoglobin, blood pressure, and BMI for adults with poor cardiometabolic health. Next, moving to hospitalizations and healthcare expenditures. Important modeling in 2023 detailed the national implementation of medically tailored meals could be associated with 1.6 million averted hospitalizations in the first year, a net cost savings of 13.6 billion in healthcare costs in the first year. Even more dramatic over 10 years is that the national implementation of medically tailored meals over that 10-year period in 2019 was calculated to be associated with 18,257,000 averted hospitalizations, reducing healthcare expenditures for a net savings of 185 billion over 10 years. And finally, we'll turn to healthcare outcome and cost effects. Another study showed that implementing prescription produce programs for diabetes in the United States and offering these PPPs for 6.5 million US adults with diabetes and food insecurity over a lifetime could prevent 292,000 cardiovascular disease events, generate 260,000 quality adjusted life years, and save 4.8 billion in productivity costs. Now that we've sort of developed that evidence-based case for Food is Medicine, I'd like to turn it over to my colleague Zoe to discuss how agriculture and the food structure in Alaska plays into Food is Medicine.
Food is Medicine is a food-based intervention, so it's important to consider the opportunities that come along with operating in connection with the food system. Food insecurity in Alaska is a pressing concern, exacerbated by factors such as the state's remote geography and limited agricultural growing seasons, resulting in challenges in food distribution and affordability, particularly in rural and indigenous communities. As you're setting up a state plan for Food is Medicine, part of the work that needs to be done is considering how interventions and programs can be designed to strengthen local food systems, enhance local economies, and increase food accessibility for the general community. For instance, Alaska's SNAP program recognizes the significance of wild food harvesting in both food security and cultural aspects. In Alaska, SNAP program funds can be applied towards supplies and gear needed for wild harvest, demonstrating how the program was tailored to the state's environment and food culture to allow participants to use funds to purchase equipment for harvesting wild foods. Food is Medicine programs could and should be similarly tailored to promote the state's food system goals and values. Food is Medicine interventions can support the consumption of healthy, wild-caught foods and strengthen local food systems by integrating or supporting the donation of traditional foods, by incorporating procurement requirements that require programs to prioritize the purchase of local foods, through building out shared food infrastructure like cold storage or high tunnels, or by passing on knowledge of traditional foodways that promote health. Spending money on local food can also stimulate the local economy through the multiplier effect, where initial spending sets off a chain reaction of additional spending as the money circulates within the economy. Studies estimate that the multiplier effect of spending on local food is between $1.32 and $1.90 for every dollar spent on local products. We're going to spend a little more time discussing this in the context of USDA funding later in the presentation, but wanted to highlight that designing a state food as medicine plan is an opportunity to create and support food system infrastructure that not only facilitates FIM, but may also have spillover effects that improve community-wide food access. Meghana is now going to provide a few other evidence-based justifications for implementing food as medicine programs.
Thank you, Zoe. So we'd like to first highlight the economic and cost neutrality benefits of food as medicine. GusNIP, which is funded by the USDA, provides competitively awarded grants to nonprofit organizations and government agencies for projects that increase the purchase of fruits and vegetables through cash incentives and produce prescription programs. Over 4 years, GusNIP awarded $110 million to 63 projects. These projects were shown to generate $85,607,933 in economic benefit for local surrounding economies. Next, we'd like to cover agricultural benefits. A relevant case study to consider here is that of GusNIP's as well, a funded project called SNAP Stretch, managed by the West Virginia Food and Farm Coalition, that allowed SNAP participants to double and sometimes triple the amount of money spent on harvested fruits and vegetables and plants, thereby supporting local producers. And finally, we wanted to highlight IHS's Produce Prescription Pilot Program. There are opportunities that prioritize food as medicine within tribal populations. And it's important to note that food as medicine initiatives, like the produce prescription programs, are being funded specifically to evaluate their impact on American Indian and American Native populations. This produce prescription pilot program was authorized by Congress to support funding for the IHS to increase access to produce and traditional foods, of utmost importance as we consider implementing these interventions in Alaska. I'd next like to move it to our colleague, and actually our supervisor, Erica, who is subbing in for our colleague, to cover the funding pathways of food as medicine.
Thank you so much, Meghana. And I am presenting the hard work of Matthew, who unexpectedly couldn't be here today. But now that we've covered the food as medicine interventions and some ways that they can support Alaska communities, we're going to look at how these programs can be actually funded and implemented in your state. Currently, there is a lot of momentum from the federal government propelling really exciting policy opportunities to address food insecurity and chronic illness, as our wonderful students have addressed. So in September 2022, the National Strategy on Hunger, Nutrition, and Health actually endorsed the testing of Medicaid coverage of food as medicine interventions through an 1115 waiver demonstrations, which we will discuss. And the Centers for Medicare and Medicaid Services, or CMS, committed to helping states who are interested in this process in submitting successful applications and to providing further guidance. The agency has actually fulfilled that promise, and in December 2022, CMS released this framework in the center with guidelines for states to submit successful 1115 proposals to cover health-related social needs services, including nutrition services. Then, just in November, on the 16th, CMS further clarified exactly which health-related social needs benefits can work with which Medicaid and CHIP pathways. Throughout the rest of this presentation, we are going to highlight various examples of how states have been taking advantage of these federal policies to advance Medicaid coverage and other coverage of health-related social needs services, including food as medicine services on the ground for beneficiaries. So Alaska can consider how you may want to adopt those policies. In this presentation, we're going to be covering various different options The reason why we have to discuss these legal payment flexibilities that can be somewhat complex is because baseline Medicaid and Medicare coverage does not provide for food as medicine services. So there are a number of different payment pathways that we can examine. So first, we're going to look at Medicaid options. These have been one of the most popular and important pathways for funding food as medicine initiatives, and we will explore various pathways in the coming slides. Federally, Medicare also provides similar flexibilities through Medicare Part C or Medicare Advantage, but unfortunately, Alaska's Medicare landscape does not really support that avenue, so we're not going to cover that today. Outside of Medicaid, we can look to find federal funding in other places like the Older Americans Act and the USDA, and we're also going to look at various grants and pilots. We wanted to highlight that, like various other states throughout the country, Alaska Medicaid shoulders many of the downstream healthcare costs related to food insecurity and chronic conditions. Just like many other states, Medicaid is the second largest state budget item in Alaska, with 36% of Alaskans covered by Medicaid and CHIP. And a lot of that cost can come from those chronic conditions, those diet-related chronic conditions that Meghana highlighted earlier, things like heart disease, diabetes, etc. Alaska does have some existing waivers, one Section 1115 Medicaid waiver, and 5 1915 C waivers, which we will discuss. So these may be able to be used to help expand nutrition services in the state, incentivize local food production, as we've highlighted, and accommodate culturally sensitive food practices. The first pathway that we want to discuss is the broadest Medicaid pathways to implement food as medicine goals in the healthcare system. These waivers allow state Medicaid agencies to apply to CMS for various changes to their Medicaid program. So like we mentioned, Alaska already has an 1115 waiver. There's various other things that states can do with 1115 waivers. But for our purposes, what we're going to focus in on is that an 1115 waiver can empower your state's Medicaid agency to pay for the full spectrum of food as medicine interventions and a full nutritional regimen. So that means 3 meals a day or its equivalent in these other interventions. And you'll see that this differs from the other pathways that we're going to discuss in Medicaid. 1115 waivers generally have to be budget neutral, which means the cost to the federal government needs to be the same with or without the waiver. However, CMS has loosened this requirement for health-related social needs, so things like housing supports and nutrition supports. So these supports do not need to be budget neutral, which is really beneficial for states. This spending is limited to 3% of the state's total Medicaid spending, which is actually a lot because, as we mentioned, state Medicaid spending does tend to be rather high. And there's also an availability for infrastructure funding, which is not available under any of the other pathways. This funding is available to actually help facilitate the delivery of services. So things like technology and workforce development, which Meghana will get into later. This is limited to 15% of health-related social needs spending. And then finally, an 1115 waiver can have the broadest reach of all Medicaid payment pathways that we'll be discussing in terms of the possible populations which can be targeted. So some example populations which other states have targeted with 1115 waivers that cover food as medicine services are populations with diet-related conditions such as diabetes or HIV, pregnant and postpartum individuals, or individuals that have serious mental illness or substance use disorder.
Thank you, Erica. So to visually represent the national movement for 1115 Medicaid waivers, supporting those food as medicine interventions that we've been talking about, we've included this graphic of the United States. There are currently 11 approved or pending food as medicine demonstrations, and we hope post this presentation, there will be more coming soon. Moving forward with our discussion, as Erica mentioned, we were asked by our coalition team members in Alaska to sort of tailor our Medicaid 1115 waiver discussion around infrastructure funds, older adult population support, tribal population support, and incarceration and reentry supports. We're first going to dive into those infrastructure funds. As Erica briefly mentioned, infrastructure funds under Medicaid 1115 waiver demonstrations are defined as funding to build community-based organization infrastructure to expand the capacity to be able to provide and implement health-related social needs programs, like food as medicine. CMS has indicated a strong interest in advancing states' community-based activities. And this is evident in CMS's provision of significant state flexibility to be able to use federal Medicaid funding in the following 4 categories. And that is technology, development of business or operational practices, workforce development, and outreach, education, and stakeholder convening. In the table on this slide, we've offered 3 state examples of the use of infrastructure funds to be able to inspire and also provide context for the way that Medicaid 1115 waivers are used in infrastructure funds. So the first example that we have is from the state of Arkansas under the broader Medicaid 1115 demonstration, Arkansas Health and Opportunity for Me, otherwise known as Our Home. Under Our Home, Arkansas established Life 360 Homes programs, where hospitals applied to receive extra funding to serve as providers and offer care coordination for 3 at-risk patient populations. And the first is supporting women with high-risk pregnancy diagnoses. The second is care coordinations for individuals with serious mental illness. And the third is being able to provide life skills and other health-related social needs for young adults at risk or part of foster care. The expenditures for these Life 360 home services was provided through those infrastructure funds that allowed for administrative costs and infrastructure not otherwise eligible for in Medicaid payment. Some examples of these allowable expenses included, first under technology, those electronic referral systems, shared data platforms. In the development of business or operational practices, that's the procurement, the planning, the development of the policies and workflows for referral management. In workforce development, those included funds to cover cultural competency training, trauma-informed training, community health worker certification, and finally, through outreach, education, and stakeholder convening, infrastructure funds to help design and produce the outreach and education materials, translations, sort of getting that community input and investment into the actual stakeholder convening. The takeaway from this example is that infrastructure funds can be used to help establish care coordination for health services and community support for at-risk populations. And many of the sometimes prohibitive expenses, like the technology and workforce development required to implement such care coordination, can be covered through Medicaid infrastructure funds. The second example that we'll provide of the use of infrastructure funds comes from California's CalAIM, which is their Section 1115 waiver, and also a 5-year, $1.85 billion initiative to help build up the capacity and infrastructure of on-the-ground partners. Under PATH's approved Cited Initiative, or the Capacity and Infrastructure Transition, Expansion, and Development, community-based organizations, federally qualified health centers, and tribal programs are able to apply for funds for initiatives like increasing the provider workforces, infrastructure to support integration into CalAIM, and outreach to undersourced or underserved populations. And the takeaway for this example is that these infrastructure funds can again be used to allocate funds for additional staff, billing systems, data exchange capabilities to be able to help under-resourced providers and community-based organizations. The third and final example of infrastructure funds usage that we'll provide today comes from New Mexico's pending Turquoise Care 1115 waiver, which was able to specify the use of infrastructure funds to provide culturally appropriate traditional healing services, managed care organization contract obligations for a full-time staff person speaking Native languages, and support for Native American Technical Advisory Committee, or the NATAC, that gives tribes and nations an opportunity to meet face-to-face with the Human Services Department to continue and expand discussion on Medicaid waivers. New Mexico's Turquoise Care waiver capitalizes on outreach, education, and stakeholder convening to support infrastructure funding through their waiver. And the takeaway here for Alaska is that infrastructure funds can be creatively wielded to expand not only culturally appropriate health services for Native populations, but also avenues for amplifying Native populations' viewpoints. Now that we've covered infrastructure funds, we'll move toward examples of waivers dedicated toward older adult population support. And as we dive into these examples, we'd like to note that some of these waivers are also a part of the Food is Medicine integration goals. You'll note that there's a green icon with a basket of fruit above waivers that combine both the Food is Medicine goal and specific population support. The first example we offer here is from Mississippi through their Healthy Mississippi waiver that proposed eligibility expansion to cover individuals aged 65 or older, or were disabled, or who did not have Medicare. Here we see that 1115 waivers can be used to reduce that coverage gap that may exist for populations wanting health insurance. The second example comes from Minnesota's Minnesota Reform 2020, under the Community Alternative Care waiver that built upon an existing 1915C elderly waiver to include the home and community-based service of home-delivered meals and nutrition services. The Alternative Care Program provides home and community-based services for people aged 65 and older who require the level of care provided in a nursing facility, but want to choose to live in the community and are not yet financially eligible for the medical assistance. Here we see that 1115 waivers can build upon other waiver types to expand previously existing infrastructure. The final example we'd like to provide is from Tennessee's TennCare 3, that used an 1115 waiver to expand eligibility and provide home-delivered meals for senior populations enrolled in an existing Choices program. Here again, we see how a state has used funding from the 1115 waivers to build upon existing programs. Finally, we'll discuss how tribal and traditional populations can be supported through 1115 waivers. We have tried here to select states like Alaska in that they are prioritizing supporting their American Indian and Native populations. The first state that we'll cover is Arizona, who submitted an 1115 waiver to update their expenditure authority language to include medically necessary diagnostic, therapeutic, and preventative dental services for American Native populations. This waiver aimed to reduce health disparities by improving oral health among tribal members. This waiver shows that if there are specific barriers to care and services for Native populations, 1115 waivers can be used to eliminate them. The second state example is from South Dakota. Here, their waiver proposal was to provide culturally competent services to American Indians by partnering with federally qualified health centers and urban Indian health clinics to be able to provide services to dual Medicaid and IHS eligible populations. Here we see that 1115 waivers can be used to leverage stakeholders like federally qualified health centers to provide services to populations that may otherwise be underserved. The third and final example is a highlighting of two efforts by the state of California to be able to engage community-based organizations. The first is the Ceres Community Project that provides medically tailored meals and groceries made with 100% organic and locally sourced ingredients, as well as cooking and nutrition education for those with diet-related disease. This example shows how health plans can partner with community-based organizations to provide locally sourced and culturally sensitive foods. The second is Recipe for Health, which offers members under the Alameda Alliance for Health, servicing Medi-Cal enrollees in Alameda County, produce prescription deliveries and organic produce sources through a local CBO called Dig Deep Farms. The takeaway here is that similarly to Ceres, it is possible to find those community-based organizations who are already invested in traditional and subsistence food production to be able to make those foods available through health plan partnerships. And of course, 1115 waiver demonstrations can help support these community level integrations. We'd like to move forward to targeted 1115 waivers for populations experiencing homelessness and populations experiencing incarceration and reentry. We'd like to note here that a benefit, again, of these 1115 waivers is that they can be used to meet multiple goals. We also know that there will be another presentation about health-related social needs services and reentry opportunities for Alaska. The first state that we'd like to highlight under populations experiencing homelessness is Arizona. And Arizona has been able to offer housing supports for enrollees experiencing or at risk of experiencing homelessness and who meet at least one specified clinical or social risk criteria. The second state is California, that has an approved waiver expansion of services targeting high-need enrollees, including individuals experiencing homelessness. The services offered in California include housing transition and navigation services, housing deposits, and sustaining services. Also listed in this table are other states that are submitting or have submitted waivers for supporting populations experiencing homelessness. Moving towards the right side of the table, we'll be able to highlight states that are submitting or have submitted waivers to support populations experiencing incarceration and reentry. A state we'd like to highlight here is California. California became the first state in 2023 to be able to provide a targeted set of Medicaid services to youth and eligible adults in state prisons and county jails and youth correctional facilities for up to 90 days prior to release. Some of these benefits that we'd like to highlight are case management, physical and behavioral health consultation, as well as medications. The second state that we'd like to highlight is Washington. That Washington was also able to deliver Medicaid services to eligible beneficiaries in state prisons, county and city jails, and youth correction facilities up to 90 days prior to release. And some of these services include case management, medication-assisted treatment services, and a 30-day supply of all prescription medications. While we know we covered a host of examples, these are in no way all-inclusive of the ways that states in the United States have been pushing forward 1115 waiver support. Now we'd like to turn to 1915C waivers.
Thank you, Meghana. So moving away from 1115 waivers, there are other funding pathways for food as medicine interventions through Medicaid. 1915C waivers, just like the other waivers, can do many different things, but we are focusing on food as medicine. Under 1915C of the Social Security Act, Medicaid is allowed to offer different services to high-risk members of our communities. These flexibilities are called home and community-based services. This 1915C waiver explicitly extends services to patients who qualify for an institutional level of care. So this is like a nursing home or a psychiatric hospital. These waivers regularly include home-delivered meals for patients, but the full spectrum of food as medicine services can also be included in this waiver. Importantly, these services can only be included up to 2 meals a day, so not a full nutritional regimen. This is in contrast to the 1115 waiver pathway that we just discussed. Under 1915C, the state must show that the services are cost neutral, so the state services cannot cost more than the institutional care would have. That's usually not too difficult to show. Through 1915C waivers, Alaska already provides home delivered meals to many individuals with different disabilities who require a nursing facility level of care. So looking at the infrastructure providing these meals can be helpful for expanding implementation of other home delivered nutrition intervention in Alaska, because you're already doing that really well. Another pathway under Medicaid is a 1915I state plan amendment, which can expand upon the populations served by 1915C waivers beyond those needing institutional care. So for example, states have expanded the populations to include those at risk of needing institutional level care. So like for individuals who have serious mental illness or at risk of experiencing homelessness, for example. This is also instituting a more permanent change to the state's Medicaid program than the other waivers that we've discussed. There's also a waiver option under 1915I as opposed to a state plan amendment that can expand the benefits to the same group of people for those that are at 300% of the Social Security income level. But the state plan amendment is the one that is more often used by states, like this example in Texas.
Perfect. Thank you, Erica. So we're now going to provide a quick overview of the Medicaid lever of state plan authority under Section 1905A, State Plan Authority. So under this, states can elect to include optional benefits that address social determinants of health under the state plan authority. And the example from this comes from California that currently has a bill that has not yet been passed that would make medically supportive food and nutrition interventions as defined a covered benefit under the Medi-Cal program upon issuance of final guidance by the department. So this bill, if approved, would require medically supportive food and nutrition interventions to be covered when determined to be medically necessary by a provider or healthcare plan. And so the takeaway here is that state plan authority can be used to add or alter coverage of benefits within the state plan for widespread coverage and access to service. And we're next going to move to the Older Americans Act.
So like 1915C authority, we wanted to highlight that under the Older Americans Act, Alaska is already delivering home delivered meals to individuals over the age of 60. So the takeaway here is that we can lean on these food delivery programs as a model to allow for a simpler rollout of similar meal distributions to a wider population should you all decide to use to expand food as medicine distribution in Alaska. So these are really great models for things that already are working in Alaska in terms of home delivered meals.
All right, and so now we'd like to cover some pilots and grants to be able to fund food as medicine. And so we wanted to note that state legislatures play a crucial role in advancing food as medicine initiatives through the creation of pilot programs and securing of grant funding, which is a strategy essential for being able to test the effectiveness and feasibility of integrating nutrition-based interventions into healthcare. And so on the left, we've provided some examples of those state legislations, and on the right, we've been able to provide examples of private and public entities that are complementing these state-led efforts with substantial financial support. And we want to note that these slides will be distributed later, and so if we are unable to go into these specific examples, you will have them for reference later. Just wanting to note that the importance of these funding through the pilots and grants lies in their ability to be able to provide initial capital and testing grounds for food as medicine initiatives. And by demonstrating the success and efficacy, these pilot programs and grants can pave the way for larger scale implementation and integration of nutrition-focused interventions within healthcare systems, potentially leading to those broader policy changes that we've been discussing and improved public health outcomes.
So the USDA provides funding directly for food as medicine programs through grants to support produce prescription initiatives. Additionally, however, it offers significant support for food as medicine interventions through regional food system development and nutrition education funding. GovSNP was established in the 2014 Farm Bill and provides funding for two types of nutrition incentives. Most closely connected to food as medicine, GovSNP funds produce prescription projects that evaluate the impact of fruit and vegetable prescriptions on reducing food insecurity and healthcare utilization. The Yukon-Kuskokwim Health Corporation, an example of a produce prescription program highlighted earlier, has received over $1 million in GovSNP funding since 2019 for its produce prescription program. The next USDA funding category to highlight is regional food system support, which funds programs for developing infrastructure and capacity to expand and scale food as medicine initiatives. For instance, the USDA recently granted $30 million to the Hawaii Good Food Alliance to establish a regional food business center, addressing challenges like food transport logistics, underdeveloped infrastructure, supply chain disruptions, and high food prices in Alaska and similar regions. Another example of using USDA funds to develop food as medicine infrastructure is the Local Food Promotion Program grants. This program funds projects that expand local and regional food businesses, connecting producers with consumers. One such grant supports Farmers Food as Medicine, a program in San Diego with over $700,000 from the USDA to provide medically supportive food from small farms. This demonstrates how food as medicine initiatives can effectively utilize USDA funding aimed at regional food system development to support local economies and food systems. USDA also funds nutrition education through the SNAP-Ed grant program. As Natalie mentioned earlier, some SNAP-Ed funding directly supports nutrition education within food as medicine projects. So as you can see, although GovSNP is a critical source of funding for food as medicine interventions, there are ample opportunities to use other USDA funding that isn't explicitly connected to food as medicine to provide critical support for such interventions. Erica is now going to wrap up our funding discussion with an overview of the pros and cons of each of the different pathways we've discussed today.
Thank you, Zoe. I want to get us into Q&A, so I will just highlight these final slides that we have for you when you're reviewing the slide presentation and this recording that compares the actors and actions, so the pathways that you take to actually apply for these funding mechanisms, as well as some suggested pros and cons in comparing all of these different funding pathways. So with that, I will pass it back to Commissioner Hedberg before we head into our Q&A. Thank you, everybody.
Great. Thank you so much, Erica. And thank you to the presenters. I know that you learned a lot and you have shared a lot about what's happening in lower 48. And to everyone that is participating, you know, in Alaska, we have a really robust tribal health system, and we're incredibly thankful for our close connections with our tribal partners and our tribal consultation process. And really, this presentation was to hear what's happening in the lower 48, and then to take that back and work with all of you in figuring out what makes sense for Alaska. We know our communities well, and hearing what's happening in lower 48 and how we can apply that up here is really what this was all about. And so I know that there was also some discussion about reentry and care coordination and housing. We actually have another webinar on that, and it's Erica put that in the chat. So if you want to register, you can learn more about what we're really putting the umbrella term around transformation of care. I also just wanted to quickly highlight for you that, and some of you are aware of this conversation that we're having as food as medicine around the transformation of care, this is really, again, under the larger umbrella of the Governor's Healthy Families Initiative. Remember, he has 3 pillars: healthy beginnings, improving access, which is healthcare and behavioral health, and the 3rd pillar is healthy communities. So all of this work, this conversation, this learning that we are discovering how other states are rolling and implementing these various new initiatives is really going to help us as we're supporting Alaskans and really meeting the mission of our department. So with that, Erica, I will turn it back to you into Q&A. I really hope, thank you for those who are staying with us, and I hope that we can really get into a really meaningful dialogue.
Thank you so much, Commissioner, and thank you, yes, to all of you. I know that we have some questions here in the Q&A. So the first one that came up is from Marge. Thank you. What does built upon other waivers mean? Re 1915C elderly. I think that's a really great question. So many states build upon other waivers, their existing 1915C or their existing 1115 Medicaid waivers to expand their services, right? So these waivers are very, very flexible. So if you have programs in your existing 1915C home and community-based waivers that are really working in your state, and you want to expand those to say different target populations, that's what build upon that waiver means. So say you wanted to take what's working for an older Americans population and target that to individuals experiencing serious mental illness, you might take that over to a 1915I state plan amendment, or you might take it to an 1115 waiver. And so that's what build upon those programs means. And if other folks want to add anything to that answer, please jump in.
Yeah, Erica, I'll just chime in, and Emily, I'm not sure if you want to chime in. Again, we're in the discovery, we're in the learning of the different options. We are hosting a series of learning opportunities. We want to make sure that we're getting feedback from our tribal partners and all of our associations and organizations to craft what makes sense for Alaska. So we have not started the process of changing any of our waivers because really we want to make sure that everyone has the opportunity to learn. And then from that, then we're going to engage in a process with figuring out what are the best waivers to apply for. So I see some of these other future questions like, how can we take advantage of this now? That's what we're working on.
Heidi, if it's okay, I'd love to jump in and respond to one of the questions that was raised. The question was that Alaska has very few farmers markets, and many communities only have access to small grocery stores that have expensive produce options. And the question was, how could Food is Medicine programs help communities that may not be able to use options like mobile transportation units to deliver produce to remote regions? And I just wanted to flag that question came in right around the time that Zoe was talking about USDA funding opportunities. So I just wanted to lift that back up. One of the I think that she mentioned was that the USDA recently granted $30 million to the Hawaii Good Food Alliance. And as I say Hawaii, you may be wondering, what does that have to do with Alaska? But what it has to do with Alaska is that it's establishing a regional food business center, and part of the region that it will cover is Alaska. And the purpose of that regional food business center is to help address challenges like transportation logistics challenges, underdeveloped infrastructure, supply chain disruptions, and high food prices. And it will be focused on expanding things like developing farms and food hubs. And a food hub is a location that can aggregate smaller amounts of produce in a community and then help distribute that to a larger population, including populations that might be receiving benefits through a Food is Medicine program. And also work with communities to develop infrastructure and value processing operations as well. And they're charged with collaborating with Alaskan organizations on these activities. And so it's things like that that can help develop and address some of the transportation and seasonality concerns that may exist in communities where you might need to develop transportation options or infrastructure like cold storage or like high rows that help to be able to produce more products in your local community. So hopefully that helps to give you a sense of some of the ways that you might be able to use a Food is Medicine program.
If I may, I just want to chime in and mention one other thing. I'm seeing kind of some comments in the Q&A. Really appreciate people putting questions in the Q&A. It helps us to know what to ask moving forward, and helps us to think about these waivers. I just want to do just a quick separation on waivers because this becomes quite complicated in different ways. So there's individual waivers. So we have individuals who qualify for a waiver within Medicaid, and they're individual waiver providers. And then there are waivers like an 1115 waiver, which just allows us to participate in Medicaid differently. So offering additional services. And so really when we're talking about 1115 waiver here, we're talking about how do we offer services, the what, the who, the how of services differently. We're not talking about an individual person. DC Ricci, is there anything else you'd want to add on that? Because I'm seeing some kind of crossover between I'm a waiver provider versus a waiver, and it can be quite confusing. And I just want to make sure that those who are listening have that kind of space as we look at this forward.
It can be very confusing. And part of what I think part of what is important for people to take away as we're beginning these conversations is that, as many of you on this call know, there's like a mix of alphabet soup and numbers, right? And those basically allow different Medicaid programs to have flexibilities to cover different things. And the reason I kind of step back and preface it that way is because there are waiver providers, there's individual providers, there's demonstration projects, there's other types of waivers. We've talked mostly about 3 different kinds, some of which we already have in place, actually all 3 of which we already have in place in some way, shape, or form, right? So people are providing services under those waivers. What we're really talking about is how do we leverage those tools to achieve the goals of supporting these health-related social needs, because they keep people healthy at kind of the most optimal phase of their treatment and their health plan. And so it's going to be important for us to dig into the mechanics of those different alphabet and numerical soup, because there's different pros and cons to many of those different tools that we can use to offer those services. But fundamentally, you know, that's for us and the consultants to figure out, with a lot of input from stakeholders and a substantial amount of tribal consultation. But it's really important to think of those waivers as tools to achieve our goals. And I think the important takeaway from this is kind of understanding what our goals are and what this landscape looks like.
And then I'm happy to just take a jump at a couple of the other questions in the box. I know we're kind of running out of time, and my favorite place is to have a lot of questions in a short period of time. So I'm going to try to take the last ones that are there and kind of tie them into one, and happy to move forward. You know, so there's a question like from Eliza about specific grocers being linked to providers. I mean, I think that's all in the implementation, and we're a ways from that on who would be able to accept those vouchers or prescriptions. It will also be a clinical change as a clinician. I myself, as a clinician writing a prescription, say I have a patient with heart failure who's being discharged from the hospital who needs a different diet because of their heart failure, their renal failure, other diet sensitive conditions. As a clinician, thinking about their diet and their food as a part of that, providing a prescription for that, and then people being able to provide those services. So all of that's going to have to grow as we think about this time and space, both culturally as well as structurally. I think thinking about how do we make sure that food and produce is accessible across the state. Again, we've talked about some of the infrastructure, but we know in Alaska that cold storage and infrastructure is a big limitation to getting food out into our most rural communities. And we are exploring ways to look at the infrastructure dollars that could be able to take advantage of that as well. There's other conversations about education and how do people know about food and food services. And as you saw, one of the other infrastructure components is that. But our goal is to really help to align the different types to that pyramid that they had shown earlier, so that this is as easy as possible for the individual who needs the food, the provider who needs it, or the grocery store who's trying to figure out what that looks like, so that there's a series of opportunities that are offered that are simple and streamlined with kind of a one-stop shop. And we've seen other states be able to do that. So there's just kind of a one-stop. Many of you guys are aware of Fresh Start Alaska, or Fresh Start program through Alaska. And the idea behind it is any Alaskan who's struggling with diabetes or obesity right now can get support and services, including remote monitoring, at a one-stop regardless of your insurance type. So you can check that out right now today for diabetes, hypertension, and obesity, and be able to get support. This is kind of building on some of the payment structures on the back end and making sure that that works for Alaska across the end. I see other comments about, can we participate in things that are already there and doing it? Dana and Nicole, who are on our group right here, can help connect you to a service that may already be there. So one of the nice things about, doing a landscaping presentation is there might be a lot more here than you realized from the beginning. And so we want to connect you to moving forward. Thank you for the positive comments that I'm seeing along these lines. I'm also seeing some comments about community health workers and the valuable source in that. And we really do see in other states community health workers, which are different than community health aides, which we're very familiar with here in Alaska, can play a really important role in this work and this service. And so we are also exploring that opportunity as a whole. And I'm just glancing through these. And there was also a comment about correctional services. And looking at how we can improve in food security for incarcerated individuals. And again, that's why we're kind of talking about both of these. And I would highlight the upcoming next waiver. Well, this one was really focused on food. The next one's really on case coordination, transportation, housing, and incarcerated individuals. So it's a little bit broader. And we are going to have a partner who's actually working here in Alaska doing a lot of these services, not really funded through the Medicaid service, talking about what this looks like in Alaska, because we're trying to learn from Alaska services overall. So as there are more questions popping in my chat box, I am seeing kind of other things pop up, but I think I got most of them. Commissioner DC Ricci, did I miss anything else or anything else that you wanted to highlight?
And you did a great job in zinking the questions and answers. The only thing that I want to make sure that everyone is tracking as well, this presentation was truly the landscape of food is medicine. All of the different options that are available to us. It's for all of us collectively to figure out what makes sense for Alaska. There's another conversation, and it's the Food Security Task Force, and there's multiple work groups. I participate on the Food Security Task Force, and that's really the infrastructure to make sure, regardless of where you live in Alaska, that you have access to those healthy, nutritional foods year-round. And we know that transportation and storage, there's some deficits in those areas. And so there's a whole group and a whole effort underway on that infrastructure. And so if you would like more information about the Food Security Task Force, please reach out to me and I can make sure to connect you in with that work as well. Emily, do you want to add anything?
I just appreciate everyone's contribution today and taking time to listen, and thank you.
Great. Erica and the Harvard students, thank you so much for taking the time to prepare and to share with us what's happening in the lower 48 and some of the best practices and to how we can take that information and help form what makes sense for Alaska. Erica, do you have any closing comments?
No, just thank you all so much for all your wonderful work in Alaska, for Commissioner Hedberg and Dr. Zink for convening this amazing group. And I'm so excited to see where this goes and to continue to be a resource for all of you. I know this was a lot in this presentation. We definitely designed the slides to be something that you can go back to as a resource and to look at those charts and to look at those links as you're continuing on in your very exciting journey. So just thank you so much for inviting us to be a part of it. And I hope this was helpful. And it was great to hear in the chat about all the wonderful work that you're doing.
Awesome. Thank you so much, Erica. And for all the attendees, please look in the chat box. There is a link to our December 5th, noon to 1:30 presentation. It's going to be bigger and broader. It's going to be really looking at that reentry housing care coordination, which is again a part of the transformation of care conversation that we're having. With that, we'll close out this webinar and have a good afternoon. Take care, everyone. Bye-bye.
Thank you all.